Well, greetings everyone and welcome to the EKG case for the week of May 20th, 2012. My name's Amal Mattu at the University of Maryland. I've got kind of a cool case for you this week. It's not a recent case. It's a case I had perhaps a number of years ago, but I've seen a couple of other cases like that, and I thought it would be a reasonable time to talk about a particular set of findings in this condition. Anyway, it's a 45-year-old woman that presented to the emergency department complaining of a severe gastroenteritis. Now, that appeared to be the main complaint, and even I wouldn't get a 12-lead EKG on a run-of-the-mill patient with the gastroenteritis, just nausea, vomiting, diarrhea. We did get a 12-lead on this patient because she looked particularly ill, and we wanted to make sure that nothing else was going on. So here's the 12-lead EKG, and as you look at this 12-lead, hopefully there's a few things that are jumping out at you. In particular, hopefully there's three things, a triad, that's jumping out at you. First of all, there's some PVCs, so that's easy enough. You know, what causes PVCs? Well, there's a lot of things that cause PVCs. We'll come back to that in just a bit. One other thing that hopefully is jumping out at you is that this patient has some ST segment depression. There's ST depression or ischemic looking changes in some of the precordial leads, also in some of the limb leads as well. So we're clearly worried that this patient may have some cardiac ischemia because of the ST segment depressions. And then the one other thing, which is perhaps just a bit more subtle until it's pointed out, is the prolonged QT. Now, this didn't jump out to the treating physicians initially because everybody was looking at the PVCs and the ST segment depression. But now I'm sure everybody can appreciate how prolonged that QT is. We've talked before that if the computer interval interpretation is not provided for you, you can just use what I call the poor man's way of getting the QT or corrected QT. Just take the halfway distance between two R to R intervals. So halfway is probably about I can't draw straight lines, but that's about the halfway point. And you'll notice that the T wave is ending beyond the halfway point. And that means that this is a prolonged QT. Normally, if somebody's got a normal QT interval, the T wave should end before the halfway point. And in this particular case, the T wave ends beyond the halfway point. So this is clearly a prolonged QT interval. So this patient has this little triad of findings: a prolonged QT, ST depression, and PVCs. And this is not a very well published, but it's actually a very specific triad for a particular condition. Before we get to that, let's briefly talk about the differentials here. What's the differential for ST segment depression? Well, we all think about cardiac ischemia. There's other things that can cause ST depression. And in reality, if you look up the differential for ST depression, we all worry about cardiac ischemia, but in reality, it's a bit non-specific. There's a bunch of other things that can give you ST depression. PVCs, also fairly non-specific. Prolonged QT, let's spend just a minute on prolonged QT because this is important. There are electrolyte problems that can prolong the QT: hypo-K, hypo-mag, and hypocalcium, right? So whenever you see a prolonged QT, you always want to think about the electrolytes. You also want to take a good look at the medication list. Now, this patient was not on any sodium channel blocking drugs that would prolong the QT. She had a history of hypertension and was only on 2 blood pressure medicines, which are not notoriously known for prolonging the QT. And there's a few other things that can prolong the QT: elevated intracranial pressure, hypothermia, but hopefully nobody's diagnosing hypothermia on 12-lead EKG, right? Just use a thermometer. That's what I recommend. Get hypothermia diagnosed at triage, not on 12-lead EKG. One commonly reported finding in the cardiac literature, not necessarily in the EM or IM literature, but in the cardiac literature, they talk about cardiac ischemia. Now, cardiac ischemia can prolong the QT. In fact, there's some literature saying that a prolongation of the QT is the very first thing that happens when a patient develops cardiac ischemia. If you were in the cath lab and you tied off somebody's coronary artery, just for kicks, I guess, you might actually see a prolongation of the QT before any other ischemic find, even before that hyperacute T wave develops that we've all been taught. But the caveat here, the reason why it's not that important to know, despite the fact that I'm lingering on it, is the fact that the prolongation of the QT with cardiac ischemia is only very slight. You don't get a massively prolonged QT when somebody's got cardiac ischemia. You just get a very, very slight prolongation of the QT with cardiac ischemia. And then once you've gone through this whole differential, that leaves you with congenital. We think about congenital causes as a diagnosis of exclusion. Coming back over to the 12-lead EKG that we were dealing with, you see that this is a fairly pronounced long QT. This is a lot more than you'd expect from cardiac ischemia. And when you've got this really prolonged QT, you've got to think about that differential that we just went through. And it turns out that severe hypokalemia is well reported to produce this triad that I just mentioned: long QT, ST depression. A lot of people don't realize this, but severe hypokalemia can produce ST segment depression and, of course, PVCs, which most people know. So this triad of PVCs, prolonged QT, and ST depression, it turns out, is probably commonly severe hypokalemia. And in fact, here's another case. This is another patient with that same triad: long QT, ST depression, and PVCs, and this was also severe hypokalemia. And everybody focuses on the ST segment depression, thinking, wow, this person's got to go to the cath lab. And the person did go to the cath lab and had clean coronaries. It turned out that this was purely hypokalemia, and once the potassium was replaced, the ST segments came right back up to baseline, PVCs went away, and the QT shortened. So this ST depression issue is not something that's well talked about, but I think it's important to know that severe hypokalemia can cause ST segment depression, and your tip-off there is that there's a long QT. If you see ST, here's another case, by the way, and this patient doesn't have PVCs. This patient has ST segment depression in a bunch of leads, and you'll notice that there's this prolonged QT as well. So just a simple take-home point from this series of 3 cases here: whenever you see ST segment depression, sure, the first thing you're thinking of is cardiac ischemia. But when you see this combination of ST segment depression plus a really long QT, stop for a second and think about that potassium level. And then if you've got PVCs in there also, then that's the third part of the triad. Sorry, I'm just learning English. That's the third part of that triad that really, really increases the likelihood that this is really just severe hypokalemia. All 3 of these cases I just showed you had severe hypokalemia. All 3 of these patients, because of the ST segment depression, they went to the cath lab and had clean coronaries. Now, I'm not telling you not to get cardiology involved, but I think the real important thing to think about is when you see ST depression with the prolonged QT, and then especially if you see the PVCs, get that potassium really, really, really fast. If you can do the bedside potassium test, get that right away and start fixing that potassium as soon as you get that level back. The first 2 cases, specifically this case and the first case that I started with, both of these patients actually developed torsade because of the prolonged QT. And I'm not going to go through the whole case presentation in terms of what happened with these patients. They ended up surviving, not necessarily with great outcomes, but everybody focused just on cardiac ischemia when they saw ST depression, and there was a significant delay in terms of replacing the potassium. The patients developed arrhythmias, didn't have great outcomes, and the point that we learned from these mistakes was very simple. When you see that prolonged QT, don't blow off the prolonged QT just because you see some ST depression. Think about severe hypokalemia in your differential for prolonged QT with ST segment depression. All right, simple enough. Hopefully that was helpful. Hopefully that'll help you avoid our screw-ups, and I will talk to you next week. Bye for now.